Yes, you heard that right. Poop out the vagina. What you should know about endometriosis surgery, part 3. I've met with 2 endometriosis specialists and a colorectal specialist, as I plan to have my own excision surgery very soon. And I want to share any valuable insights that I've gained from my private consultations. So far I've talked about endometrioma removal's impact on egg reserve and whether both pelvic and abdominal endo can be operated on at the same time. Today I'm going to go deep on the surgical risks associated with the bowel. You may have already seen my post on the risks of bowel surgery, where I mentioned stoma and bowel fistula. Here's what you need to know when it comes to surgery. Well, let's dive a little deeper. Here's what I learned in my consultations. And let me give you a heads up. It ain't pretty. Firstly, stoma. Now, I don't know about you, but ever since I was diagnosed with endometriosis in January 2016, I've had the word stoma thrown at me by every single gynecologist to put me off having surgery. The fear of stoma has been weaponized to discourage me, and I imagine many of you, from insisting on having surgical treatment. It was always referred to as a high probability risk, even a guaranteed one by some gynecologists. And of course, most of us, especially when we're first learning about this disease and therefore know very little about treatment, will happily walk away from putting ourselves at such risk, right? Well, what's been intriguing is how the consultants I met with referred to stoma risk. Now, they both said it's case dependent, but in most cases, risk of stoma is less than 1%. Less than 1%. Now, risk rates can be defined in different ways. There are generic risk rates and there are individual. The consultants were speaking to their own individual risk rates as per their own patient outcomes. I can't speak to how NHS hospitals evaluate their risk rates, if it's based on their individual hospital, whether they're part of a group of hospitals, or the NHS risk rates across the board. But if it is that high in any respect, there's something wrong here. Because here's the interesting part. How stoma risk is evaluated, as I understood it. Time to get the diagram out. Here is the bowel. So it starts here, ends here at Uranus. If endometriotic lesions or nodules are located higher up on the bowel, approximately 10 to 15 centimeters from Uranus upwards, the risk of stoma in most cases is minimal. If, on the other hand, the lesions are located towards the lower end of the bowel, nearing your exit, the risk of stoma is high and in many cases a very likely outcome. Why so? The lower down in the bowel, the higher the pressure. Let me explain. The bowel muscles contract as they process waste that turns into poop. The rectosigmoid colon, which leads to your rectum, your exit, tends to be under more stress as it needs to pass poop, evacuate the content of your bowel. So let's say there's a case of endometriosis where a patient has endometriotic lesions or nodules quite low down in that part of the bowel. And they're sizable enough and have penetrated the bowel wall enough that they require a resection. To perform a resection at this part of the bowel and then sew these parts back together, the pressure point this low down is too high, which means there is an increased risk of the bowel resection breaking and causing leakage, which is why there is an increased chance of requiring stoma for recovery. And I was told by both consultants, always a temporary stoma. Moving on to bowel fistula. A bowel fistula is a post-op complication where the bowel makes a connection with another organ. Now, I'll be honest, I didn't quite fully understand what this could possibly mean. Then the colorectal specialist gave me an example which literally had me going, no, wait, no, surely not. Wait, what? Get ready for this. Apologies for my awful artwork. So, here you have a leg and an arse. Just so you can understand, this is the in between your legs part. So the pink is your vagina, that's your cervix, and the green is the rectosigmoid, the rectum, the rectosigmoid colon, your bowel. Okay? If a bowel fistula occurs between the bowel and, say, the vagina, the organs make contact. They make a connection, they connect. And what that can mean is that the contents of your bowel may start emptying into your vagina. Poop in the vagina. Yes, you 100% heard that right. I could not believe my ears. So yeah, that was pretty eye-opening. On a positive note, I was told that the risk, as per the consultant's experience, though he seemed to apply it generically, is very low these days, by the way. But honestly, the human body and its capabilities continue to amaze me. Now, I hope no one watching has experienced any horrible complications. Nonetheless, you're more than welcome to share your surgical experiences in the comments.